This is the primary tumor review of the pathology section for the USMLE Step 1. Primary tumors of the brain occur at an incidence of about 10 per 100,000. The main classes that we want to keep in mind are the gliomas and meningiomas. Gliomas come in three different types: astrocytomas, oligodendrogliomas, and ependymoma. An astrocytoma is a tumor derived from astrocytes, which is a type of glioma. The main types of astrocytoma that you want to keep in mind for the USMLE include glioblastoma multiforme, or GBM, and pilocytic astrocytomas, which occur in children and in the cerebellum. GBMs make up 80% of adult primary brain tumors. They usually arise in the cerebral hemispheres, and they usually present with headache, seizures, or other focal neurological deficits. On the left, you have a gross demonstration of a GBM, and on the right, you can see the hypercellularity of all of the cells making up a GBM. They are predominantly astrocytes. Oligodendroglioma is most commonly seen in the 4th and 5th decades. Here, patients have several years of neurologic complaints, including seizures. They are typically found in cerebral hemispheres, especially in the white matter. The clinical features is an average survival of 5 to 10 years of long-standing neurological complaints, including headaches and seizures. On pathology, oligodendroglioma demonstrates a fried egg appearance of the cells. On the left, you can see the dense nuclei with the surrounding white halo. The white part is the white part of the egg, and the nucleus is the yellow yolk. On the right, you have a zoom in of the same image. Ependymomas arise from, as you guessed it, ependymal cells which line the ventricles. Here, the clinical features are hydrocephalus because the ependymoma grows into the ventricle and obstructs the outflow of CSF. These disorders have a poor prognosis, but should be kept in mind whenever you see a mass near the ventricular system. Neuronal tumors are rare, but there are a few. Cerebral neuroblastoma is the main one to keep in mind. These are very rare but highly aggressive, and they resemble peripheral neuroblastoma. They are composed of small undifferentiated cells with the characteristic Homer-Wright rosette. If you see Homer-Wright rosette written, think neuroblastoma. Medulloblastoma makes up 20% of brain tumors in children. It is located in the midline of the cerebellum, and there is rapid growth which may obstruct the outflow of CSF, leading to, you guessed it, hydrocephalus. Dissemination of the tumor into the CSF is common and can lead to metastases, in a sense, in the spinal cord. It is highly malignant, but at least radiosensitive, and it can be treated to some extent. Here's a CAT scan of a child's brain demonstrating a medulloblastoma in the midline of the cerebellum. If you look at the lateral ventricles as well as the third ventricle, which is right in the middle, you'll notice that the third ventricle is rounded and the lateral ventricles are slightly enlarged. Again, this is due to obstructive hydrocephalus leading to increased pressure. Meningiomas are benign tumors. However, the fact that they are in the rigid skull and there isn't much stretching in the skull, you can have herniation or subsequent serious side effects. So we try to remove them surgically when identified. They typically arise from the meningothelial cell of the arachnoid layer, and the pathology involves rounded masses with well-defined dural base that compresses the underlying brain, which may give rise to the symptoms. The clinical features, because of the fact that they are slow-growing lesions, leads to chronic complaints, and the tumor size is usually much bigger than you would expect for the patient's symptoms. Here you have a coronal section of a gross brain. You can see the corpus callosum in the middle. Do you see the meningioma? It's at the top. Do you see it on the left side, compressing the cerebral hemisphere from the top? And it is coming off of the meninges, pushing downwards. As you can imagine, this could compress the sensory strip, the motor strip, or both. However, because it's growing slowly over time, perhaps years, the symptoms may be minimal as the brain adjusts for its slow compression. Metastatic tumors. These make up the majority of intracranial tumors in adults. Lung, breast, skin, renal cell, and GI tumors, specifically from the colon, are the most common metastases to the brain. They usually are sharply demarcated masses, and they are often at the gray-white matter junction. Schwannomas arise from, as you guessed it, the Schwann cell. They're usually sporadic but can also be seen in neurofibromatosis type 2. If you do see it in neurofibromatosis type 2, you should expect to see two of them, meaning one schwannoma on each side. Another term for schwannoma is neuroma, acoustic neuroma. So the clinical features would, as you imagine, involve the eighth nerve, typically tinnitus and hearing loss. Neurofibromas. Common forms of neurofibromas include cutaneous neurofibromas and solitary neurofibromas, typically in the brachial plexus or in the lumbar plexus. They arise sporadically or in association with neurofibromatosis type 1. Skin lesions present as nodules with overlying hyperpigmentation of the skin, whereas well-delineated but encapsulated masses are composed of spindle cells that can cause trouble with irritating the plexi. Just a comparison here of neurofibromatosis type 1 and type 2. Neurofibromatosis type 1, the key things are the pigmented nodules, cafe au lait spots, and the neurofibromin protein. Whereas neurofibromatosis type 2 will give you bilateral acoustic schwannomas or acoustic neuromas with multiple meningiomas, as well as gliomas, and it encodes the protein myelin. Remember, neurofibromatosis type 1 is a peripheral problem. Neurofibromatosis type 2 is a central nervous system problem. Here is an example of the neurofibromatosis type 2. Do you see the abnormality? If you look on the left of the image, there is an acoustic neuroma that is abutting next to the brain. Let's do a question. A 6-year-old boy experiences ataxia and headaches then has sudden onset of vomiting and becomes comatose. Head CT shows a 4-centimeter mass in the region of the cerebellar vermis and dilation of the cerebral ventricles. Lumbar puncture yields CSF with numerous small cells with dark blue nuclei and scant cytoplasm, indicating hypercellularity. What is the most likely diagnosis? The correct answer is medulloblastoma, D. Why? Any child with a tumor at the vermis of the cerebellum in the midline causing obstruction almost undoubtedly has medulloblastoma. Glioblastoma multiforme would be very rare in this age, and the other two, A and B, cytomegalovirus and cryptococcus, would have other signs of infection. Meningioma would be possible, but again, at the age of 6 years would be very, very unlikely. Next question. A 40-year-old woman complains of decreased right-sided hearing for several months. Head CT shows a sharply circumscribed mass adjacent to the right pons, extending into the left inferior cerebellar hemisphere. The most likely lesion is A. Medulloblastoma, B. Meningioma, C. Schwannoma, D. Ependymoma, or E. Glioblastoma. The correct answer is schwannoma. It sounds like she has an acoustic neuroma or acoustic schwannoma that's involving this cerebropontine angle. She has extension to the cerebellar hemisphere, the right pons, and she is describing hearing loss for several months. That goes along with an acoustic neuroma. That ends the tumor section of the pathology review.